Hello, and welcome to your program on how to write a prescription for pedorthic treatment. I'm Teresa Alpert with the University of Colorado in the Department of Foot and Ankle. We're going to review the anatomy of a foot orthotic. This is a very important component because you can manufacture, fabricate, and design an orthotic to accommodate a variety of modalities. So the anatomy of a foot orthotic, it always starts with the shell of the orthotic. And this could be made out of a variety of materials, from something that's very accommodative to something that's very rigid. And from the shell, you'll add what type of posting or correction you want on that orthotic. And then you would add a padding material or any forefoot accommodations like metatarsal pads or offloadings, and then a top cover. Bottom cover is an optional item. I like to finish mine because it slides into the shoe easier. One of the disadvantages is that if you want to do any grinding or modifications later on, then you would be scuffing up the bottom material to do that. So a demonstration of the orthotic up on the right-hand corner, you see that is not a finished one, and that is a rigid material with a external heel post and a lateral wedge to correct for supination. On the picture in the center, you see that you have a bottom cover, you have the heel post, the shell, a metatarsal pad as an accommodation, you have pour-on for a padding, and a top cover. Orthotics come in a variety of materials, rigid being stronger materials, carbon fiber or graphite, copolymers. There are many different types of materials, and rigid orthotics are biomechanical functional orthotics. Here you are trying to provide a correction to correct medial or lateral position at heel strike and to control where that foot hits the ground. So rigid orthotics are functional. Semi-rigid orthotics are heat moldable, usually made out of also plastics or cork material, but they're semi-rigid. They have a little bit more flex to them. The durometers aren't as strong, and they're a little bit more forgiving to your patients. And they can come with a variety of top covers. Again, you can modify these. They don't often have as strong as a functional capabilities as a rigid orthotic, but they are very, very effective in controlling the foot. And then you have accommodative orthotics. These are soft materials. This is for cushioning, offloading materials. They're usually used for total contact. This is for, like I said, shock absorption, offloading. These are materials like this with plastizote pink top covers that we use for the diabetic or insensate or neuropathic foot. So now let's take a moment to talk about foot conditions and how we're going to use our orthotic protocols to manage conditions. So for forefoot conditions, such as bunions, hammer toes, malatoes, sesamoiditis, neuromas, hallux limitus or hallux rigidus, turf toe, corns and calluses. These can all be managed with orthotic protocols. But first, we must pay attention to footwear. You know, you'll often hear me say to my patients, I don't care what fancy orthotic I may make for you. If you're not wearing the proper footwear, all is for naught, because the orthotic is only as good as the footwear that you put it in. So we must look at the shoes that our patients are wearing. If you have bunions or hammer toes, you must have a wider shoe, a deeper shoe. You must consider where the seams are on the shoe, soft upper material so it can be stretchy and accommodate where those bony prominences are. If you have a neuroma or sesamoid issues or turf toe hallux limitus, you want a stiffer sole shoe so that you can prevent the break of the shoe with each push off moment, or to have a shoe with more of a rigid rocker sole. So shoes are the first line of pedorthic prevention and management of the foot. And learning about footwear inventory is very, very important. And we'll speak about a little bit of that later on in this presentation. Then you can go to your orthotic. For all of the forefoot conditions, I recommend a full-length orthotic because you're dealing with the forefoot. And accommodative materials also because you need something that is softer where you need to offload corns and calluses. But yet for a hallux limitus or turf toe, you may need something more semi-rigid or a combination of materials like a trilaminate underneath the great toe or the first MPJ joint to reduce the motion. So understanding the pathology and how the foot works in motion is very important in the design of your orthotic. And accommodations that you would use on that orthotic could be a metatarsal pad or a bar if you are supporting the entire metatarsal parabola, or a dancer pad if you want to offload the sesamoids. Do you need a turf toe extension because you're wanting to support that first MPJ joint for turf toe injury? Offload cutouts for corns and calluses, callosities, as I said. And don't forget the socks. You know, if you're dealing with forefoot conditions, socks have seams. So even something as benign as a seam could be problematic if it's rubbing against the skin and causing friction against the callus. There are socks that are 2-ply. There are socks that have no seams. And there are socks that also provide compression if you have a patient that has some mild edema or swelling in their feet.
Sure.
So in the Pedorthic Toolbox, there's a pad for everything. These are just examples of first-rate cutout to support an offload there for someone with sesamoid itis, or a dancer pad in the center there to show you a placement of a hang pad or a felt pad to offload under the first MPJ joint and then disperse the pressure over the metatarsal parabola. And then you also see on the far right a turf toe extension, and then finally a carbon fiber plate. So each of these do a different thing. And like I said, there is a pad for everything. Over-the-counter medical grade orthotics, they are available. You can go into athletic running stores. You can go into many outlets and find ready-made orthotics. It's important for you to know what they are so that when your clients, patients are coming in and you're looking in their shoes or they're removing their orthotics, or you're asking the questions, are you wearing orthotics, that you understand what they are wearing. Some of these medical grade orthotics will go over, but some of them have extended turf toe built into them. Some of them are just medical grade pour-on to offload pressure areas and absorb shock, and some are heat moldable. So this may be something that you bring into your office and provide for your clients. Here's an example of an over-the-counter medical grade orthotic that's very low volume, and it has a metatarsal pad in it. And this is great if you're looking for something to go into cleats. It's wonderful for metatarsalgia, neuromas, and hammer toes. So every one of these offers a different feature and a different benefit. Moving on to plantar fasciitis, which is usually the number one reason people complain about foot pain is plantar fasciitis. So we like to throw the bucket at this. Again, you need supportive footwear. I tell patients to use Birkenstock sandals. They are an orthotic footbed with an upper. Cowboy boots. Why? Because they have an elevated heel. This shortens the tension on the plantar fascial band. Also, a rocker sole is helpful, and a high top. So if we disperse the pressure on the plantar part of the foot and take the load off of that and bring it up to the ankle, that will reduce pressure on the plantar fascia. Orthotics, semi-rigid or functional orthotic. Remember, we're building up from the floor to the foot, from the ground to the foot. A deep heel cup so that we can contain the fat pad underneath the heel will be its own best shock absorption. Remember, plantar fasciitis does not just only present with heel pain. It is the plantar fascia band, and it innervates through the metatarsal heads. So patients that are complaining also of metatarsal pain, that could also be directly related to the plantar fascia band. Accommodations, make sure that arch is completely filled and that there's direct contact to the patient. You could do a heel plug for offloading or a horseshoe cut out if it's very sensitive at the insertion at the calcaneus. Using compression socks or padded socks. Also a night splint. And I cannot stress enough how important calf stretching is. And I don't mean calf stretching to do 20 minutes or just to go to PT therapy and do it at that time. I mean throughout the day. I'm often suggesting doing toe curls in their shoes, curling your toes, holding, and releasing, putting your foot up on a chair and pointing your toes to your nose, and getting a stretch that way throughout the day. I tell patients when you get up from your chair, use it as your exercise tool. Put your foot on the chair, point your toes to your nose each time you get up. So stretching throughout the day. In our Pedorthic Toolbox, we have again Birkenstock sandals, Philippos heel cups, building that arch up to the foot, like I said, stretching and using night splints if needed. For sleeping can also be very helpful. Over-the-counter medical grade orthotics are available as a first go-to, again, for plantar fasciitis. Studies have been done to show that between bespoke, being custom orthotics versus an over-counter orthotic with plantar fasciitis, that there wasn't much difference between both of them in the outcomes of managing plantar fasciitis. So most important is to get that support on the foot and to do the stretching exercises. This is an over-the-counter orthotic. This one particularly has a 12 millimeter heel cup, so you are containing the fat pad. It has a 3-degree medial post to control the pronation. So, some over-the-counter orthotics are better than others, just as an example. So let's move on to Pronation Pes Planus. Okay, so pronation isn't a bad thing. Everybody needs to pronate in order to push off. Athletic footwear often provides a great amount of stability, and you can look at the shoe and see that it has a medial guardrail or a flare, a medial flare on the athletic shoe that can control the pronation. You can look to see about medial counters. High tops are always best to control pronation, excessive pronation, boots, and a stiffer sole. In orthotic management, you can use a semi-rigid or a rigid orthotic. The deeper the heel cup, especially for severe pronation, you would use something more like a UCBL, and that stands for the University California Berkeley Labs, if that ever comes up on a board exam. An SMO, which is a submalleolar orthotic, comes up just above the malleoli, or an AFO in severe cases to control pronation. Accommodation, medial forefoot post, and a soft top cover. The reason why you would want a medial forefoot post is because you're controlling the hind foot with a medial post. But that's great. But if you have a heavier set person, they're going to overrun that and just run right off of the orthotic, and you haven't controlled the forefoot. So think about the foot like a washcloth. The heel is going in one direction and the forefoot is going in the other direction. So you want to control that foot so that you get the best outcome with each step. And form-fitting socks are helpful as well. So something that may have a little bit of arch retention in the sock. In our Pedorthic Toolbox, you can see this orthotic here has a medial post and a forefoot post. You can also use a deeper heel cup using more rigid materials. You see here on this athletic New Balance shoe, I have a medial buttress, which it be used for very severe pronation. You can use heel posting wedges as well to control the hind foot. The supinated or Pescavus foot can be more challenging from an orthotic perspective. You need a deeper shoe. Adjustable uppers can be very helpful. Laces, straps, and zippers because they have a higher instep to don the shoe. That can be very challenging for a very fixed Pescavus foot to get into what we call the throat of the shoe. Orthotics are full length because this is a tripod foot. I think a full length is better because there's more pressure on the metatarsal and on the heel of the foot. So I like to use a full length. Soft top covers, a deep heel cup, semi-rigid. Accommodations, you need to fill that arch. A lateral wedge post because the foot is supinating, it's rolling to the outside. A metatarsal bar or a pad. A toe crest because often these patients are curling or perching their toes to get balance and appropriate perception is helpful. Arch support socks and a bubble toe, a sock without constriction can also be helpful. In our Pedorthic Toolbox, you see here is a arch support that has a higher arch, but it also has a lateral flange to hold the foot in position because if you're building up the arch, you just don't want that foot to roll off to the side. You want to be able to contain it. You can use scaphoid pads and arch pads to build up to the foot. Also in the shoe down on the bottom here on this athletic shoe here, there is a lateral buttress here to keep the patient from rolling to the outside, and orthotic control management with a lateral post here on the outside. Over-the-counter medical grade orthotics are available. You're looking for a deep heel cup that provides superior support in controlling that. It is a prefab UCBL that I mentioned earlier. They're also heat moldable and available as well. This is a good alternative to a custom, especially if you're working with children and juniors because they're still growing. So keep that in mind if you're working with the pediatric population, that you may want to look at medical grade available orthotics that are less expensive in the growing population. Functional orthotics. Functional orthotics are needed when we need to do more control or provide biomechanical assistance for our patients. So they are semi and rigid foot orthotics. UCBLs, as he said, are University of California, Berkeley Labs, the SMO, supramalleoli orthotic, and an SCFO, a subtalar control foot orthotic. So each one has to and must, as I circled here, regardless if you're using any of those orthotics or going up the biomechanical chain in an AFO or a KFO, a type of orthotic device, must interface with the footwear. Again, it's always about the footwear to make sure that everything is functioning and interfacing appropriately. Combinations of UCBLs and SMOs. Why do we use them? We use them for posterior tibial tendon dysfunction. If you have an extreme flat foot, sinus tarsi syndrome, severe plantar fasciitis, osteoarthritis. Sometimes we'll use these types of AFOs if we want to do something to put off a surgical intervention for time and see how a patient is going to respond to having their midfoot controlled prior to a surgery and see what the outcome is going to be. Custom AFOs. Now, is the foot flexible or fixed? This is a question that must be evaluated, because if you have a fixed deformity and you're designing a hard, rigid, fixed AFO, that is what you're going to get. So you cannot correct a fixed deformity in a fixed orthotic. You're only going to get same as same. But if you have a flexible foot, you can correct it in your cast model to a more neutral or corrected position. Why would we use an AFO going over the ankle? We would use it for posttibial tendon dysfunction. We can correct those tendons to a more neutral position and give more functionality, reduce pain, and create stability for the patient. In the back, the Crow Walker, the black brace, is a clamshell walker. We would use that for a Charcot foot, where we have to have offloading and stability. The AFO carbon fiber dynamic action AFO we would use for a drop foot. This is a dynamic action AFO. I like to use these because the patients don't atrophy in this. At heel strike, it brings up the foot. It's a dorsiflexion assist AFO. So again, you need to know the pathology. You as a physical therapist know the range of motion, what your patients can achieve, and work together with your orthotist and your pedorthist to pick the best modalities for your patients. Rocker soles are very important. You have metatarsal rockers will take off the pressure on the forefoot. Liz Frank rockers will take off the pressure in the Liz Frank area of the foot. And a double rocker, you don't see this very often. You might see it on exam. Takes off the forces on the midfoot and distributes it over the heel and the metatarsal. All of these rockers have a different purpose in offloading the position of the foot. And we use a lot of this in diabetic foot care management when we want to offload ulcers. You'll also need to use a rocker or an equinus elevation lift when you have a fixed equinus foot. So just to familiarize yourself with different rocker elevations, a good shoemaker can provide these elevations for you. But know that this is available as a modality for your patients. A lot of footwear today comes with rigid rockers. For example, like Danskos have a rigid rocker. Hokas have a rocker bottom. Some of them come with a carbon fiber plate in them so that they are a rigid platform. Depending on the stack height of the Hoka, you will have some that will provide you with stability and the rocker. So know, again, the footwear. I would suggest that you go into your local sit and fit shoe stores and work with your shoe fitters and have them bring out a variety of shoes and detail them with you so that you understand the differences of the platforms, the stack heights. Talk about ultra shoes or topos or a myriad of shoes that have square toe boxes, oblique toe boxes. Accelero is another wonderful line of footwear that has a carbon fiber shank to offload the hallux first MPJ, and they also have that it offloads the fifth metatarsal for Jones fracture. So footwear, again, is essential, and more of the footwear companies are designing these rocker benefits into the footwear so you don't have to do these external modifications. Writing the prescription is important to let your orthotist, let your pedorthist know what you want. In your notes or writing a prescription, working together on the team with your referral source is critical to managing your patient together. It is a team. It takes all of us. It takes your patient, it takes you, it takes someone like myself coming together to create the best outcomes. I want to thank you for this opportunity of sharing and learning together. If you have any questions, don't hesitate to call me. I also would encourage you to join the PFA and look at our website at pedorthics.org. There is a directory there with a list of pedorthists throughout the United States and network. And thank you again very, very much for this opportunity to share.